Hello, my name is Abby Wiedoff, and I am a fourth-year pharmacy student at Drake University. Today I will be presenting on anaerobic coverage and aspiration pneumonia. The views of this presentation are my own and reflect the data from the reference section at the end of this presentation. The objectives for this presentation are to understand the definition of aspiration pneumonia, identify common bacteria and community-acquired pneumonia, or CAP, evaluate therapy required to cover common bacteria, and determine when to expand to anaerobic coverage and what therapy would be appropriate in these situations. Aspiration pneumonia is an infection that occurs when bacteria is introduced to the lungs via food, saliva, liquids, or vomit being breathed into the lungs or airways leading into the lungs, instead of being swallowed into the esophagus and stomach. Pneumonitis, which is a non-infectious acute lung injury, frequently occurs when patients aspirate gastric contents. However, symptoms generally subside within the first couple of days with only supportive treatment and no antibiotic use. The inflammatory conditions that occur after aspiration can lead to favorable conditions that allow for bacteria to grow. Aspiration pneumonia is reported to account for about 5 to 15% of all cases of community-acquired pneumonia. However, it is difficult to estimate as most aspiration events go unwitnessed or are silent. Standard diagnostic criteria is lacking based on the difficult differential diagnosis. The most recent update of the IDSA guidelines suggests not routinely adding anaerobic coverage to standard empiric treatment for CAP for aspiration pneumonia unless lung abscess or empyema is suspected. Listed here are the common pathogens identified in CAP. It is these pathogens that guide our decision of which antibiotics to use empirically when treating CAP. This table shows the recommended antibiotic agents for empiric inpatient treatment of non-severe CAP, according to the IDSA guidelines. It is recommended to use a beta-lactam in combination with a macrolide. Studies have shown that addition of a macrolide to beta-lactam therapy is associated with better clinical outcomes for patients with CAP. An option for adults who have contraindications to both recommended macrolides is combination therapy with a beta-lactam and doxycycline. If a patient has a beta-lactam allergy, then monotherapy with a respiratory quinolone should be used. This is typically reserved for patients with an allergy due to safety risks. This table shows the recommended empiric inpatient treatment of severe CAP. Coverage for Pseudomonas and MRSA is added if the patient has risk factors for these infections. If the patient has risk factors for Pseudomonas, the regimen must cover both S. pneumoniae and Pseudomonas. MRSA NAIRs can be collected and therapy can be de-escalated appropriately if negative. If cultures are collected and susceptibilities come back, therapy should be de-escalated as soon as possible. Anaerobic bacteria coverage for aspiration pneumonia is based upon studies from around the 1970s. These studies showed high rates of anaerobes isolated from patients. However, these results were most likely due to the use of transtracheal aspirates and the inclusion of patients with late-onset disease. More recently, studies have suggested that anaerobic bacteria do not play a major role in etiology of aspiration pneumonia. Some complications that can occur from anaerobic coverage include increased prevalence of antibiotic-resistant pathogens and an increased risk of C. diff infection. Anaerobic coverage may be used for patients with risk factors such as severe periodontal disease, necrotizing pneumonia, or lung abscess. When anaerobic coverage for aspiration is warranted, Common anaerobic bacteria covered are listed on this slide. Typical additional agents for anaerobic coverage include beta-lactam and beta-lactamase inhibitors, metronidazole, and clindamycin. Clindamycin is typically used as more of a last-line option if an allergy is present. It is necessary to evaluate these options to ensure that these agents, along with the standard therapy regimen, appropriately cover all the bacteria that are of concern. It is important to cover all necessary pathogens, but to combat resistance by choosing agents that are most narrow on the antibiotic spectrum of coverage. In conclusion, the IDSA guidelines suggest not routinely adding anaerobic coverage to standard empiric treatment for CAP for aspiration pneumonia unless risk factors are suspected and present. When anaerobic coverage is warranted, it is necessary to evaluate treatment options to ensure that the patient is on narrow empiric therapy that will appropriately treat the aspiration pneumonia. Thank you for listening to this presentation. My references are to follow on the next slide.